Morning, ladies and gentlemen. Thank you very much for the invitation. It's very exciting to be here. This is my third time at the Mayo, and I'm always impressed by the vitality and energy that you have over here. So I'm going to be talking to you about safety of drugs and the genomics of the safety of drugs. Just as an aside, that non-medical emergency that you had before was related to the fact that they predicted that there was going to be a fire based on the electrics. They didn't need a randomized controlled trial, they didn't need an implementation phase, and they didn't need any regulatory support. Obviously, I wish my genomic tests were as accurate, and I had to go through it that quickly. I could go through it that quickly. But let's see how we get on today. So these are the learning objectives. I won't go through them in great detail. What I'm going to do is start off with a quote from Louis Pasteur. So what I tend to do in terms of the research that we undertake in the two centers that you can see at the bottom of the slide is that we go from discovery right through to implementation. And that's a long pathway. And it's a complex pathway, a very rocky pathway, and full of hurdles and challenges. And I'll take you through some of those. Because it's such a long and winding road, you really have to get your inspiration from wherever you go. And I'll start off with this cartoon, and it's about Watson and Crick. They were having difficulties in defining what the structure of DNA was, and they went to a pub in Cambridge. And if you've been to Cambridge, there are lots of nice pubs in Cambridge. And they were sitting there musing about what they were going to do next, and a chap comes along and says, "I'll have a double, Felix," and you know what happened next. So let me start off with a classification of adverse drug reactions. You can divide them very broadly into two types. One, which is an on-target reaction, which is really based on the known primary or secondary pharmacology of the drug, the way it interacts with targets. And there's a clear dose-dependence relationship. As Paracelsus said, the dose is the poison. The more you give of the drug in with on-target reactions, the more likely you are to get an adverse drug reaction. And you can reduce the dose, and hopefully the adverse drug reaction goes away. More difficult are the off-target reactions. These are not predictable from the knowledge of the pharmacology. They're often called bizarre or type B reactions. They don't have a normal dose-dependence relationship, but there is a complex dose-dependence relationship, and there's often genetic susceptibility factors. However, genetic susceptibility factors are there for both on-target and off-target reactions, and I'll go through both of those through my talk. So here's the burden of adverse drug reactions. It's a busy slide, but I'll take you through this very quickly. So the first two balloons there are studies that we conducted within the northwest of England. And basically, these are the largest studies of their kind in the world. And what we showed was that 6.5% of all patients admitted to our hospitals were admitted because of adverse drug reactions. When a patient is admitted to hospital with an illness, disease process, their physiology is changing all the time, the pathology is changing all the time, and the doctors are changing medications to be able to control the disease process. And in that situation, 15% of patients will develop an adverse drug reaction. So overall, the burden is high, and we're not bad prescribers in the Northwest England. This is seen in every part of the world, and these data have been replicated in many different countries from the Far East right through to the United States. The next two balloons are studies in the United States. Emergency room attendances, 2.5% are due to adverse drug reactions, while in ambulatory care, 25%, 1 in 4 patients will get some form of adverse drug reaction. Most of it is mild, but some of it is severe enough to cause admission to hospital. So overall, the burden, if we equate that to the overall bed base, for example, the United Kingdom in the National Health Service, at this very moment in time, there are 8,000 beds occupied by patients with adverse drug reactions. 70% of those are potentially avoidable through better prescribing. And you will all know of the famous paper that appeared in JAMA by Jason Lazarou, which said that in the US, adverse drug reactions are between the 4th to 6th commonest cause of death. This was based on 1994 figures. I don't know whether it's still true, but it probably many things haven't changed. So when we start looking at what factors contribute to adverse drug reactions, clearly there is a genetic contribution. Many factors do predispose to adverse drug reactions. Many of them are environmental. Many of them are clinical based on our practice. We don't actually know what the overall genetic contribution is, but it may vary according to the drug and to the reaction that we look at. In some cases, it's almost always genetic. In other cases, there is a very small genetic component. So it's very much like a complex disease and Mendelian diseases. Some of the things I'm going to describe to you are almost like Mendelian diseases in terms of the genetic influence. Others are very much like complex diseases with very small genetic influence. So it's not just genetics, that's very important. And it's not just genomics. We have to look at all the kinds of omics technologies, as was mentioned yesterday. One thing that is very important is actually improving prescribing as a means of preventing these adverse drug reactions. And so the British Pharmacological Society in the UK has been heading up initiatives to really try to improve drug prescribing with the educational efforts, online prescribing, educational software, but also we've now managed to persuade the Medical Schools Council in the UK, the 31 medical schools in the UK, that every medical student who graduates will have to do a national prescribing safety assessment, which is up to standard so that we know what their prescribing skills are, so that they can be safer when they start looking after patients when they go and work as interns. So that's a kind of non-genetic area. So in terms of genetics, what I want to do is to cover 3 areas. The first one is genomics and drug dosing. Second is genomics and drug choice. And the third one is electronic health records and linking genomics, and give you a UK perspective. You heard a lot from Dan Roden yesterday in terms of what's going on at Vanderbilt. So if we look at drug dosing, I think that we are very poor at drug dosing. And this is seen by data from the FDA. That data from the FDA shows that 20 to 30% of drugs which are introduced into clinical practice have had to have their doses reduced after they've been on the market for a short while because the dosing was too high when they were first introduced. And as we move forward in the genomic era, we will have to be much more clever about our dosing. We will have to individualize dose. And if we want to really get to individualized medicine, we can't use the different kinds of doses, the very small number of doses that we have. We'll have to be much more individualized in terms of dosing. And one drug where dosing is very individualized is warfarin. And I'm going to take you through the story of warfarin. Several people mentioned it, but didn't really go through it in detail yesterday. You may have had it on Wednesday, so if you have had it, I apologize for that. But I'll take you through it from my perspective. So warfarin is the commonest oral anticoagulant still used all over the world. In the UK, about 1% of the population are on warfarin, and about 1 to 1.5% of the US population are on warfarin. The dose range is very wide. Some people require ½ milligram a day. Some people require 20 milligrams a day. So there's 40-fold variability in dosage. And the problem is that if you get the INR wrong, INR goes up too high, greater than 4, then you get bleeding, as seen in this 82-year-old patient on the slide who had a calf hematoma. And warfarin still remains one of the commonest causes of adverse drug reactions causing hospital admission because of bleeding. And so what we need to do is to become much better in terms of dosing for warfarin. So work which has been undertaken by many groups in the world, including ourselves and many groups in the United States, has shown that these are the factors which determine daily warfarin dose requirements. So for example, age, height, and weight account for 10 to 20% of the variance individual daily dosing requirement. Drug interactions account for 5 to 10%, and amiodarone is particularly important here. Then there are genetic factors, and you can see the genetic factors actually account for a greater proportion of the dose variation dose requirement than any of the clinical factors. So cytochrome P452C9 is responsible for the metabolism of warfarin, the S enantiomer of warfarin, and there are many different variants which lead to reduction in the metabolism of warfarin, and therefore you require lower doses. Vitamin K epoxide reductase complex is the enzyme which warfarin inhibits to cause inhibition of vitamin K-dependent coagulation factors 2, 7, 9, and 10, and therefore causing anticoagulation. And you can see the VCOC-1 accounts for about 25% of the variation, while cytochrome P452C9 accounts for 15% of the variation. And in order to convince you even more, here's unpublished data from a UK prospective cohort which underwent a genome-wide scan. And you can see that unlike the Manhattan plots that you get with complex diseases, that you're getting really two peaks here. One on chromosome 10, which is cytochrome P452C9, and one on chromosome 16, which is vitamin K epoxyl reductase complex. And you're reaching p-values of 10 to the minus 50 with only 700 patients. Now, when I was a Ph.D. student, I was very glad to get a p-value of 0.05. Now all my experiments have to rely on a p-value of 5 times 10 to the minus 8. And that's how times change. So on the basis of that, we undertook a trial, which was called the EU-PACT trial, which was funded by the EU Commission in Europe, and it took place in the United Kingdom and in Sweden. Now, these are two countries which have well-developed anticoagulation practices. And if you look at the world ranking in terms of the ability to control patients for warfarin, Sweden is number 1 in terms of anticoagulation control, and the United Kingdom is number 4 in terms of anticoagulation control. And what we did was we recruited 454 patients. 226 were randomized to the genotype arm, and 228 were randomized to standard care arm, the standard care that is delivered in Sweden and in UK. And what we did was use the point of care test for genotyping. That is, the patient gave us a small amount of blood. There's no DNA extraction. It went into the machine there, and within 2 hours, it gave you a result on 3 alleles, the 2 cytochrome P450 alleles and VCOC-1. And that test result was then fed into a computer software algorithm, which told you what the dose was for the next 3 days for those patients randomized to a genotyped arm. And we completed this trial last year and published the data in the New England Journal of Medicine. And what we had as a primary outcome measure was the percentage of time within therapeutic INR range of 2 to 3 for the first 3 months following the initiation of warfarin therapy. And so if you look at the standard dosing arm on the slide there, you can see that even within 3 months, we got a very good TTR, which is 60.3%. Now, most clinics in real clinical practice don't achieve that even after many years. So within 3 months, even in the control arm, we'd got to 60.3. Yet in the genotyped arm, we'd got much higher, 67.4, with a 7% difference, which is highly statistically significant. And let me show you the Kaplan-Meier plots on that. First of all, on the international normalized ratio. So what we found was in the genotyped, in the international normalized ratio in the control arm, what we were getting is an upswing with an INR going above 3, yet in the genotyped group, we weren't getting that upswing, and it was much better controlled without those wild swings that you get in INR in certain patients. And then in time and therapeutic range, the genotyped group was much better in terms of achieving a higher time in range, as you can see with separation occurring between the genotype group and the control group at about 10 days. And this continued throughout the end of the 3 months. So this was a positive result from our perspective. However, at the same time, in the same issue, the trial, which was run in the United States, which is called COAG, showed there was no difference between genotyped and controlled arms. And this has led to a lot of confusion. For example, the headline from Genome Web was that 2 conflicting prospective randomized control trials provide no definitive guidance to physicians. And clearly that is true. An editorial accompanied these 2 trials. And the author of the editorial said the conclusion of the studies are similar. I'm not sure I agree with that conclusion, given that there was a 7% difference in one and no difference in the other. So let me just take you through a perspective of why there were differences between the EU-PACT and COAG and randomized control trials. What this tells you, randomized control trials can lead to as much confusion as observational studies, depending on the design. So the clinical practice certainly does vary between the United Kingdom, Sweden, and the United States. For example, in Europe, we tend to use loading doses at the beginning of initiation of warfarin. I believe in most US clinics, you don't use loading doses, you start off on a maintenance dose. And because we use loading doses, our algorithmic strategies were completely different between the two trials. And algorithmic strategies are key to be able to dosing out appropriately. And we worked on very hard on developing a good algorithmic strategy for the first 3 days, and we simulated that in a simulated trial before we started this. Also, COAG was much more heterogeneous in terms of ethnicity. You can see that 27% of the participants were African American, whereas in the EU-PACT, it was 97% Caucasian. And it's important to note, as you heard yesterday, that the frequency of genetic variants varies according to the different ethnic groups. So cytochrome P450, 2C9 star 2 and star 3, which were the alleles which were looked at in both of the trials, are rare in African Americans. So basically African Americans weren't getting the appropriate dosing because the alleles such as star 6, star 11, etc. were just not present in the algorithm. It's also been suggested that what we looked at was current clinical care, which is what in the EU-PACT, which is fixed dosing. Whereas in COAG, there was a clinical algorithm which contained all factors apart from genetics. And this has been interpreted as that genetics does not add anything over and above the clinical factors. And some people have actually advocated the use of a clinical algorithm. However, it's important to note that nowhere in the literature is there a randomized controlled trial which has tested clinical algorithm versus fixed dosing. And so what we are looking at here is an example of genetic exceptionalism, that you accept a lower degree of evidence for something which doesn't include genetics. And despite that, you can see that in terms of time in range and the comparison between COAG and EU-PACT, you can see that our time in range within EU-PACT, because the algorithmic strategies utilized, were much greater, much better than that obtained in COAG because of a different algorithmic strategy. And we achieved, for example, 67% TTR at 3 months, whereas COAG wasn't able to get above 51% at 3 months. So that is one issue that has helped us in terms of taking it further. And I'm going to show you I'm going to tell you what we're going to do with our next steps. Also, we've done some further analysis, and this is unpublished data, which has looked at the number of variants. And if you don't have any variants at all, then the genotype algorithm is no better than the fixed dosing. And you can see there's no significant difference. But if you have 2 or more genetic variants, your algorithm works much better than when you don't have any variants at all, with a highly significant difference and a p-value and an adjusted difference of 11%. Now, it's been suggested that 7% difference was modest, and 11% difference is also modest. But please note that from the literature, a 10% improvement in your TTR leads to 20% improvement in clinical outcomes. And this is taken from the RELIVE trial, which looked at 20,000 individuals. So overall, we feel that using the algorithmic strategies and the clinical practice in the United Kingdom and Sweden, we feel that our algorithmic strategies have worked, and genotyping guided dosing does help. And what we are doing at the moment is a cost effectiveness analysis of this and taking it to the next stage to be able to take it into implementation in the UK. Let me go into drug choice. And I'm going to focus in on HLA here. You heard about this yesterday. HLA is the most polymorphic region of the human genome. On chromosome 6, the short arm, and there are 3 different regions there. HLA class 1, which is ABC, class 2, which is DR, DQ, DP, and class 3 is in between the class 1 and class 2 regions, which has genes such as TNF-alpha, MICA, and heat shock protein. And the best paradigm of how HLA can prevent adverse drug reactions is seen with Abacavir. You will all know the story of Abacavir, so I'll go through this pretty quickly. Abacavir is an anti-HIV drug which causes hypersensitivity in about 7% of individuals. And work undertaken in Australia and then in the United States was able to show a very strong association with HLA-B star 5701. In the United Kingdom, we were able to replicate this, and we also undertook a cost-effectiveness analysis in the context of the National Health Service. We were able to show that if we were to introduce 5701 testing in HIV clinics, we would be able to save money for the UK NHS. And this study was published in 2004. By 2006, every patient in the UK who had to go on Abacavir was having an HLA test before they went on Abacavir. And the net effect of that has been dramatic. So for example, if you look at the data in Australia, incidence has gone down from 7% to less than 1%. And for the last 5 years, I have not seen any case of Abacavir hypersensitivity because of genetic testing which is done. And that tells you genetic testing can prevent adverse drug reaction, and is a true example of personalized medicine. Importantly, this has also led to mechanistic insights. So crystallography studies using HLA-B57.1 have led to new hypotheses as to how these hypersensitivity reactions occur. Our MHC clefts is occupied by peptides normally, which leads to the tolerance mechanisms evident within our immune system. However, when the patient with this allele is given Abacavir, Abacavir binds to the pocket in the F part of the cleft, and it leads to a change in the binding of different peptides. So you get a different peptide profile. And this particular theory, which is called the peptide displacement hypothesis, basically says because you're getting these changes in peptides within the MHC cleft, when the Abacavir is bound there, leads to your body recognizing that as being non-self or foreign, and leads to an immune reaction. Now, this has been shown in vitro. It now needs some proof in vivo, but it tells you something about the mechanistic hypotheses and mechanistic angles that can arise from these kind of studies. So we've been very interested in carbamazepine, and carbamazepine is a much more complex phenomenon than Abacavir. That's another non-medical emergency, I hope. And I'm going to take you through 3 patients that I looked after. The first one is a patient who had a mild rash, a bit of itching, and I had to stop the drug, and the patient improved with antihistamines. Patient 2 was the most severely affected patient. They had something called DRESS, or hypersensitivity syndrome. They had rash, and the ALT went up to over 1,000 when they were on carbamazepine. They were in hospital for 3 weeks, and this phenomenon of DRESS, or hypersensitivity syndrome, has a mortality of about 10%. The third and most severe phenotype is called Stevens-Johnson syndrome. And this patient here had blistering affecting 60% of the body surface area, which is similar to having third-degree burns affecting 60% of your body surface area. And this patient had toxic epidermal necrosis. They were in the hospital for 2 months in intensive care, requiring plasmapheresis, plasma exchange, etc. And the mortality in this condition is 30%. And carbamazepine can cause all of those phenomena. And so work which has been undertaken in Southeast Asia has shown a strong association with 1502, the HLA 1502. This was first shown in Han Chinese population, but then has been replicated in other Han Chinese groups, as well as in Thai population, as well as Malaysia. And you can see that if you have HLA 1502, you have about 113-fold increased risk of getting SJS/TN compared to somebody who doesn't have that allele. And this is now in the label. The FDA has put into the label. The European Medicines Agency has also done the same. We've been interested in the local population in the United Kingdom and Northern Europeans. And we were able to identify a new HLA allele, which is 31.1, also published in the New England Journal of Medicine. And that was based on a GWAS done only in 22 patients with hypersensitivity syndrome. And we were able to show one peak in chromosome 6, which we later underwent and did sequence-based typing and showed that this was related to 31.01. Now, this finding has been replicated in Japanese patients, in Chinese patients, South Korean, Canadian, and in other EU populations. So it's been replicated all over the world, and we've calculated that you need to test 47 individuals to prevent 1 case of carbamazepine hypersensitivity. At the moment, it is in the drug label, but it's for information only. It's not mandatory as 1502 is. And what we're trying to see is what other evidence do you need to be able to put that into clinical practice? And just to show you the differences in terms of allele frequencies which determine why 1502 is important in Southeast Asia, but not in other parts of the world. So if you look at 1502, it's mostly prevalent in Southeast Asia, which is where the associations with carbamazepine has been found. It's not really found at all in the United States or in Europe. Yet 3101 is found all over the world with high frequency of frequency about 4 to 10% in different countries. So on a global scale, 31101 may have greater public relevance because of the widespread prevalence throughout the world population. So we've been undertaking cost-effectiveness studies, and this is again unpublished data. And basically what this shows is that by typing people who are going to go into carbamazepine 43101, that will be a cost-effective maneuver. And these are cost-effectiveness curves which show that at the threshold that NICE uses in the United Kingdom of £20,000, there's an 80% chance that this will be cost-effective. And so we are going to submit this to the regulatory agencies to see whether we can actually move that along the implementation pathway in the United Kingdom. So since the beginning of this century, there have been 24 different adverse drug reactions which have been associated with HLA alleles as shown on this slide. Some are related to hypersensitivity, as I've talked to you about, but also some are related to drug-induced liver injury. And at the moment, apart from 57.1, none of these are used routinely in clinical practice. And one of the things that we, in terms of trying to enhance clinical implementation, is that we're working with a company at the moment, and we're developing a multiple HLA biomarker panel, and this is funded by the UK National Health Service. We're taking all these different alleles, putting them onto one biomarker panel, and we're going to provide the test results back to the physicians within 48 hours at a cost of £20 to the UK NHS, which is a very low cost, and at that cost, it will be cost effective. So it doesn't matter if you don't need all the HLA alleles now, but as you get older, you will need treatment for your gout, in which case you will know what your risk is for allopurinol hypersensitivity, and it will be in your electronic medical record. So very much on the basis of the preemptive genotyping that Dan Roden described to you yesterday. So we are progressing this area in terms of hypersensitivity throughout the world. So I lead a consortium called the International Consortium on Drug Hypersensitivity, and it's shortened to ITCH, and it was called ITCH for appropriate reasons because of the skin rash that patients get. This is sponsored by the International Serious Adverse Event Consortium, and we've got 12 international centers involved in it with 50 UK centers, and so far we've identified and recruited 1,500 patients throughout the world. One area that hasn't really been looked at in the literature is type 1 reactions, anaphylaxis, and this is a paper just published yesterday in Journal of Allergy and Clinical Immunology, which looks at fatal anaphylaxis in the United States. And medications are the commonest cause of fatal anaphylaxis in the United States, accounting for 60% of cases. And the drugs implicated are antibiotics, particularly beta-lactams. And we've been collecting cases of beta-lactams. And again, this is data with the SAEC, again unpublished, and looking at penicillins. And what we're beginning to identify here, and I'll go through this very quickly, particularly with the type 1, which is the middle Manhattan plot, we're identifying signals within HLA, within the HLA region, but also in non-HLA regions as well. And we are replicating these associations at the moment before publication. But again, I think we're going to have strong genetic predisposing factors, again, for beta-lactam-induced type 1 reactions in the near future as well. So let me take you to the last aspect, which is really linking genomics with electronic health records. In the United Kingdom, we have something called the General Practice Research Database, which has recently changed its name to the Clinical Practice Research Datalink. It collects data from 593 primary care practices. It contains 10 million patients with 45% who have follow-up for at least 5 years, 59% of patients who have 3 years follow-up. And so it contains over 62 million years, patient years of follow-up so far, and is geographically representative and ethnically represents the population of the whole of the United Kingdom. And it's been used by the FDA, this database, by the European Medicines Agency, and by pharmaceutical companies to be able to look at drug safety signals. And many of the papers have been published in prominent journals, such as the New England Journal of Medicine, Lancet, etc. And so what we said was that can we link some of these data to undertake a feasibility study and get biological samples linked to these clinical records. So what we did was to undertake a feasibility study using statin myopathy as a paradigm. So when we looked at the database at the time, there were 641,000 patients prescribed a statin on that database. 127,000 of them had a creatinine kinase measurement. And our phenotype that we were using was a creatinine kinase of either 4 times upper limit of normal, or the more severe phenotype, which was greater than 10 times upper limit of normal. And so what we wanted to do was to really look at the genetics of this. And so while we started collecting, this paper was published by the Oxford group in the New England Journal of Medicine, which showed that there was a very strong association with this drug transporter, SLC01B1, and statin myopathy. It was particularly associated with simvastatin at 40 and 80 milligrams. And they implicated this on the basis that it leads to an increased exposure and therefore increased levels in the muscle, and therefore the myopathy that occurs in some patients. So we asked the question that when we'd collected enough samples, can we actually do a proof of concept study and prove that in our phenotype that we can actually replicate this? And this was published in Clinical Pharmacology and Therapeutics last year. And we were able to show that when you look at all myopathy cases, there is an association with SLC01B1 with our cases recruited through the electronic health record. More importantly, then when you look at simvastatin only, there's an association with simvastatin but not atorvastatin, and there's also interaction with dose. The higher the dose, the more interaction do you have with this particular genotype, and the higher the risk that you have. As you can see, per C allele, the risk is highest with 6.28 odds ratio. So we replicated that, and we are happy with our phenotype, happy with the electronic health record collection. We've now gone on to do further work on this particular area. So Ron Krauss from the PGRN published this very nice paper which showed the GATM expression associated with statin-induced myopathy. So we've actually tried to replicate this. Unfortunately, we can't get replication of this particular locus. And this has just been published as a letter in Nature last month. It was not only ourselves that couldn't replicate this, but Bruce Satie, using a cerevastatin group of patients, was also not able to replicate this, and he published it in the same area. But we've gone on to do further work, including some exome sequencing in these patients, and we've also undertaken a genome-wide association study. And this is also unpublished data in 28 patients with a severe myopathy that is CPK above 10 times upper limit of normal, or rhabdomyolysis. And this peak that you're seeing here is SLC01B1. But there are other hits which are biologically plausible, which we're again replicating, undertaking some functional work, as Dick Weinschelbaum talked to you about yesterday, to be able to get a multi-marker panel which will allow us to be able to then define who is at risk of statin-related myopathy in the future. So let me just take you to some things which are happening generally in the UK. We're very keen on electronic health records, and we feel that's going to be very important in terms of implementing personalised medicine into the future UK healthcare systems. And so because of this, the UK government has funded 4 centres which are widely distributed with the sub-centres in different cities and so on, and put in £39 million, about $50 million of infrastructure to develop this UK health informatics research centres. And the aim here is really to link up electronic databases, to be able to get the electronic data, to be able to use that for secondary research, identify signals of adverse drug reactions, but also to link it to biological archives so that we can identify the kind of genetic predisposing factors that I've just talked to you about just now. And stratification or personalization of medicine in the future is going to very much depend on how we use our electronic health records. So this is a way to go forward for us. In addition to that, the UK government announced the 100,000 Genomes Project, announced by the Prime Minister last year. And basically here, we're going to recruit 100,000 patients, DNA samples, from patients with rare diseases as well as with many different cancers. So with the rare diseases, we'll have trios, And from the cancers, we will have those somatic genome as well as the germline genome, and to be able to look for new biomarkers. And in a way, this is transformational for the UK National Health Service. What it's going to do is to actually put in new variants which are identified straight into their medical record and get the data back to the clinician and to the patient and to tell them what the implication this may have for the clinical care. And in a way, if this succeeds, then it will also go into the area of adverse drug reactions, etc., hopefully, so that we can actually take that through as well. So we don't have to undertake randomized controlled trials all the time. If we're going to have 1 million variants, we can't undertake 1 million randomized controlled trials, and we need to be much more clever in the way we use evidence from different sources in terms of actually saying this is really important, this has clinical validity, this has clinical utility, so that we can take that into clinical practice. So let me summarize. I've got 28 seconds left. Genetic factors are important in predisposing to severe adverse drug reactions. The pathway for translation of biomarkers varies, and one size does not fit all. And this, it can be seen in terms of success rates on the slide. George Post did a nice editorial in Nature. We said in the PubMed there are 150,000 papers on biomarkers, yet only 100 have been translated into clinical practice. So it is a rocky road out there, and we do need to work together to be able to take this through the clinical care system. And I think the pathway for adverse drug reactions will depend on the frequency of adverse effect, the severity, and the effect size of the genetic factor. And further advances will require multiple stakeholders with the development infrastructure, as I've talked to you about in terms of e-health records, but also it's got to be international. No center has individual numbers of cases like the severe cases I've described to you, and that's why it's important to collaborate all over the world to be able to identify those patients so that we can take it into all ethnic groups and identify genetic predisposing factors for all of those ethnic groups. So let me acknowledge the people who work with me, as well as some of our funders and many of the different organizations that I've been involved with, and thank you very much for your attention.
Thanks very much, Doctor. You were closing there on the point about international collaboration and the importance of that. And we do coincidentally have a question, I think, picking up on that theme as to whether or not there is right now any sort of international group that's working to standardize the pharmacogenetics testing around the world.
I don't think there is a global group that's doing it, but within each country or within Europe, there are groups that are working towards that. I think the International Conference on Harmonization is developing some guidelines on that as well, but other people may know better on that. Certainly, we're trying to work in Europe to be able to develop guidelines so that we can take these things through. And we certainly collaborate with the PGRN effort on CPIC, which is developing guidelines on some of these important drug association phenotypes. But the important issue here is really collaboration across the world, because if you look at some of these rare diseases, adverse events, no center has enough cases, and we really need to be able to build those cases with a standardized phenotype. And some of the work we've done, which I didn't describe today, is that you've got to be very careful about your phenotype. You need to standardize your phenotype. Make sure that your phenotype is correct, and then we can recruit them. And if you get your phenotype right, then hopefully your genotype will flow from that.
Okay. Great. A question from the audience. Should we focus on point-of-care pharmacogenomics or on getting the information in the electronic medical record ahead of time?
I think it depends on the particular adverse effect you're looking at. Preemptive genotyping is difficult to, at the moment, it's difficult to persuade the healthcare managers in the National Health Service to say, we want to genotype 10,000 people. We don't know how many of those are going to get a drug. We don't know how many of those are going to develop an adverse drug reaction. And so they'll say, well, actually, I'd rather spend my money on doing 400 hip transplants, hip replacements. So where we've gone about it is to say, well, actually, if I can develop a cheap test at the point of need, that may be easier to implement. And hence, we were keen for the warfarin trial to have a point-of-care test, which gave us the result within 2 hours. That point-of-care test has now been refined, and it now gives you the result within 35 minutes.
Okay.
And so it can be done by the nurse at the sort of bedside, and the result available in 35 minutes.
Wonderful. Speaking of warfarin, there is also a follow-up question on some of your comments on that. And given that those studies have not been conclusive, the questioner asked, should we stop using pharmacogenomics for warfarin, or should we carry out a definitive study? And I don't know how challenging and costly that might be.
So a definitive study would need quite a lot of funding. It would need probably 20,000 patients. It would also need clinical endpoints as the outcome measures, bleeding or the risk of thromboembolism as the outcome measures. And so that would cost several tens of millions of dollars to be able to undertake. And so my feeling is, because warfarin is a generic drug, nobody's going to fund that at the moment. And so what we have to do is to use the evidence that we have and implement that in the right way within your own country setting. Obviously, we do have all these new oral anticoagulants at the moment as well, and they provide choice. But if you still look at what's going on in the anticoagulation field, warfarin is still the #1 drug despite the availability of new oral anticoagulants. And the UK's National Institute of Clinical Excellence suggests that what you do is you try patients on warfarin, first of all, for 3 months. If you can't get them controlled, or if they have problems, then you switch to the new drugs because of the or because of the cost. So what may be possible in the future is that you actually identify those individuals who are not going to be able to tolerate warfarin, and then you can start the new drugs from the beginning. So you're stratifying treatment from the beginning rather than the trial and error approach that we're still using.
And I think you were anticipating my follow-up question with respect to, what might be the next steps in terms of improving the safety of those oral anticoagulants.
I think a trial whereby you actually looked at the pharmacogenetic dosing of warfarin versus one of the new oral anticoagulants might be the best way to be able to show which is the best treatment and which patients benefit from the new drugs versus the warfarin, which has been around for 60 years.
And that's a more cost manageable type study you could envision?
It would still be costly, but because of the need to be able to undertake that study and give physicians the choice and the evidence in terms of taking this forward, I think that's worthwhile arguing for with the funding agencies.
Interesting part of a scientist's job these days, huh? A question from our audience. Will next generation sequencing ever replace old-fashioned PCR, for instance, given how tough that gene is, the CYP2D6, and how important it is for so many medications?
I think it will replace it. It's only a matter of time. So 2D6 is a very complex gene, and we're looking at how we can start implementing that, and we will require next-gen sequencing to be able to do that. I think what we need is not only the ability to be able to do it in a cost-effective manner, but also the software to be able to read the what the sort of different variants mean and give the sort of decision-making to the clinician at the point of care. So the clinical decision support systems which work with that next-gen sequencing are going to be extremely important. The same thing is also important with the HLA. HLA is extremely complex. At the moment, if we did sequence-based typing, we may get a lot of variants which we don't know how to interpret. So we've, at the moment, still undertaking PCR-based approaches, but as we get much more clever about this, learn much more about the HLA system, I think the next phase will be where we do HLA sequence-based typing for everybody and put that into the electronic medical record.
And final question, because much of our conversations here at this conference have revolved around electronic medical records and the role that they're increasingly playing in this field. I was very struck by the investment that's being made by the UK. Would you like to elaborate a little bit more on that, or tell us sort of where that's going to take you?
Sure. So I think for the last 10 years, every primary ambulatory care practice has had electronic medical records. What we've been relatively slow at, but this is accelerating, is having electronic medical records in secondary care in hospitals, and the linkages between primary and secondary medical care. So what these e-health informatics centers allow us to do is to develop that infrastructure within secondary care, link it with primary care, so the whole of the 60 million population of the UK becomes linked up. And when you have a 60 million database, you can actually answer a lot of questions. And that's the scalability of this. And that's the importance of actually doing something at scale, so you can actually look at rare diseases as well as common diseases and try to identify the clinical factors as well as genetic, as well as other factors which are important in determining how you respond to a drug.
Well, I bet you're getting pretty excited about the prospects of 60 million in a database.
Yeah.
Wonderful. Dr. Pirmohamed, thank you so much.